All right, well, let's go ahead and get started today. I'd like to remind everybody to please have a look at this flyer that's on the tables. It's got a QR code that needs to be scanned in order to log into the CME system. Even if you don't really want CME, it really helps if you can log in, and so we can keep track of attendance and justify purchase of food and continuing these events. So today it's my pleasure to introduce Dr. Adam Farmer. Adam, for those who don't know, is a Johnson City product. He went to Milligan for undergrad and Quillen for, I guess, both medical school and pediatric residency. Now he's our chief resident. He has numerous presentations and honors, including chief resident this year, as well as Gold Humanism Society recently. So I think it's well deserved. He has no conflicts of interest, and today he'll be talking to us about international adoption medicine. So.
Thank you very much, Dr. Dodd. Thank you. Thank you. I believe I know everybody in this room fairly well, so it's nice to see you all again. Thank you all so much for coming to Pediatric Grand Rounds. Today I'm going to be talking about a subject that is fairly near and dear to me, international adoption medicine, and why it is important, especially for the outpatient pediatrician. Again, I have no conflicts of interest or disclosures to make. These are the objectives for my presentation today. I'm going to be talking about how pediatricians can help guide families as they consider and pursue the oftentimes arduous journey that is international adoption. We're also going to discuss some of the prenatal exposures that different kids can be exposed to prior to them walking through your door. We are going to be talking about how to evaluate the newly adopted child's growth and development. We're going to be talking about different infectious diseases that need to be on your radar, as well as how to screen for said diseases. We're also going to be talking about other medical conditions that we need to be aware of for international adoptees. And finally, we're going to talk a little bit about the neurocognitive and different behavioral issues that can be seen in international adoptees throughout their lifetime. So this is why I care about international adoption medicine. This is my little sister, Claire Jinglin. Jinglin was the Chinese name that she was given when she was placed in an orphanage. She was left by her family to be found by the orphanage, and she spent the first 14 months of her life in a Chinese orphanage there. The image on the right with the red background, or the left, sorry, with the red background, is the first image we ever got of Claire. It was emailed to my parents after a very lengthy process of trying to be approved for the adoption process. The images there on the right are some of the first interactions my parents had when they were picking up Claire from the orphanage in China there. These pictures are kind of bittersweet for me. They're some of the first images I have of my sister, so I like seeing them. At the same time, if you know my little sister at all, she looks fairly sad, I think, in these pictures, especially the very first picture. She has a lot more personality, I guess, than these images indicate. This is the very first time I met Claire. This is in the Tri-Cities airport with me and my family, and we had a fairly big group of extended family who got to meet her there. She had been with my parents for about a week or so in China, and I feel like she was already starting to bond with them and kind of come out of her shell a little bit. It was a fun time getting to see her there. And then this is an image, a couple images of her now. She is 14 years old, going on about 30. She is a typical teenager. She has won numerous medals with gymnastics. She's also an amazing aunt to my little baby there. She is a typical teenager. She spends way too much time on her cell phone. Is very embarrassed to be seen with me in public, of which I exploit as much as I can. But that's kind of why this subject is important to me, as getting to grow up with Claire and see everything that she's been through as well. So why are we talking a little bit more about international adoption? Why should you all care about it? Well, since 1999, United States families have adopted over 250,000 children from other countries. These children are usually raised in institutions or orphanages prior to them being adopted by U.S. families. They oftentimes come from resource-poor countries with different endemic infectious diseases that we may not interact with on a normal basis here in the U.S. They oftentimes can show signs of neglect, malnourishment, and different developmental delays as well when you're first evaluating them. These kids require specialized medical attention. When they walk through your door for that first or subsequent well child checks or anything like that, you can't necessarily treat them like you would one of your U.S. families who's been born and raised here in the U.S. So they need extra special attention. This is a map we got from the State Department's website. That's where a lot of the statistics and things from today I was able to get from, showing the different countries that have been participating in international adoption, or that United States families have been adopting from. The darker colored countries are the more the countries where most of the kids are coming from. China has close to a little over 78,000 kids since 1999. Russia, 46,000. Guatemala in Central America has almost 30,000 kids, as well as Ethiopia in Africa are some of the biggest countries of origin for these kids. Some of the demographics, again, over 250,000 kids since 1989 have been adopted. Approximately 61% of these have been female. A lot of that is partially due to the one-child policy in China that ran for close to 40 years. It's now been bumped up to a two-child policy since 2016, but we're still seeing a lot of the effects from that policy in our gender demographics. And the vast majority of the kids who've been adopted are being adopted under the age of 2 years old. The State Department also helps you, lets you break down each state to see how many kids have been adopted by families in different states. Just highlighted Tennessee there, has had 5,743 kids, one of which is Claire, who's been adopted since 1999. Other states like California, Texas, New York are where a lot of kids have been adopted to. And this is a graph here that shows the rate of international adoption in the United States. 2004 being the peak, where close to 23,000 kids were adopted that year. That peak seems to coincide particularly with a couple of news stories that came out in this previous couple years about kind of the dire situations that were occurring in some of the orphanages that these kids were being raised in. Really kind of heart-wrenching stories that really encouraged a lot of people to pursue international adoption. But it has been a very steady decline ever since then. And while the numbers here are dropping every year, I think it's really important to remember that all of these kids are still here. They haven't gone anywhere. So while the rate is dropping, we're still seeing lots of kids, and we're going to talk a little bit more about how internationally adopted children can have a lifetime of sequela. So it's stuff that you need to keep on the forefront of your mind. I did want to mention very briefly the Hague Convention on International or Inter-Country Adoption. This was signed into law in 2000 by President Bill Clinton. And what it did was basically had three tenets that were trying to protect kids from some of the kind of horror stories you had heard about inter-country or international adoption beforehand, kids being removed from families and being put up for adoption, really kind of terrible things, families putting their kids up for adoption thinking that they were going to get them back. Stuff that was really hard to hear. So this convention really sought out to try to correct some of those misuses there. So let's talk a little bit about before adoption, things that you need to be aware of. Again, lots of these children have been institutionalized in overcrowded orphanages and things like that. Unfortunately, long-term studies of these kids are fairly lacking. Ultimate development is pretty uncertain. There are lots of risks associated with being in a crowded orphanage. Different risks include a lack of medical care, exposure to different infections, inappropriate medical care. There was reports of children being medicated to help sleep or to be quiet and things like that. Growth and development delays, neglect, both emotional and physical, poor nutrition, as well as some reports of abuse being occurring in these different orphanages. Again, the research is fairly sparse, but there was one article I came across that looked at effects of early adversity of Romanian children. It was published in 2000. It's a small study, a little over 100 kids. They looked at these children who were coming from a very poor situation in a very resource-low Romanian orphanage. The results, they aren't great, but they roughly show that about a third were doing well 10 years after they had been adopted. A third were having some minor residual problems, and another third were having pretty serious medical, developmental, or behavioral sequelae still 10 years after being adopted. Of note, that article mentioned that age at the time of adoption was the most predictive factor. Those adopted younger had less sequelae. This is an image of a young Chinese boy, I believe, in an orphanage, showing some of the signs you can potentially see of neglect. This is kind of unusual posturing, staring at the hands. This is stuff that you see in kids who are in environments that are not stimulating enough. This is also an image of a Vietnamese orphanage. There's images like this all over that just show kind of the crowded nature. I think there's over 30 people or over 30 children in this room. And interestingly, not any caregivers in this room either. All of these kids notably do have mobiles, but no other toys or anything like that to stimulate them. Some of the effects of institutionalization, again, you can see stereotypic behaviors and things like that. Rocking, head banging, head shaking, abnormal hand movements, biting, tantrums, indiscriminate friendliness, where kids will be super friendly to every adult they come in contact with as kind of a survival mechanism for getting more attention in the orphanages. Pain insensitivity or high threshold for pain, and sometimes just inappropriate behaviors can also be seen. Hopefully these are all transient. A lot of especially the stereotypic behaviors up here can remind people of autism spectrum disorder behaviors, which can be pretty concerning for a lot of parents. But the hallmark of these behaviors being a product of institutionalization is their transient nature, that they do resolve with time and they shouldn't be pervasive. So you may be asked as a pediatrician to meet with the family before they adopt. We would encourage that. It's a very good thing to do with the families to kind of help review and interpret any of the medical records that they might have. These records may be inaccurate, they may be incomplete, and that's important to know and communicate to the parents. Also, translated medical records can be an issue sometimes. One article I found mentioned the phrase perinatal encephalopathy. When we hear that in our country, to our ears, we hear hypoxic ischemic encephalopathy, possibly cerebral palsy, things like that. But this article is noting that at least in Russia, perinatal encephalopathy can refer to any kind of social, perinatal, physical exam finding at all that might suggest a risk for neurological injury. Even the birth process itself was a risk that the babies had to recover from things. So things like that can be misleading to our ears when we read them. You also want to maybe discuss some of the common problems seen in internationally adopted children. This is a great time to look at photos, videos as well. Those can be, you can help review those. If you see any kind of facial dysmorphisms or any abnormal behaviors, you can discuss what those might mean for the families. And hopefully every record will have at least one growth chart. That seems to be fairly universal, and that it can be really important. It's oftentimes the only real objective measure we as pediatricians are going to get, and it might be the most reliable information we can see. Microcephaly can be a pretty big red flag. If you notice that, you can be worried about possible malnutrition, fetal alcohol spectrum disorder, genetic disorders, or even perinatal brain injury when you see microcephaly. Again, when you're talking to the parents who are going to be pursuing an international adoption, it's good to prepare them, although they probably already know how emotionally taxing and time-consuming it can be. There is a wide range of how long it can take. It's usually over a year, oftentimes up to 3 to 5 years to get fully through the process, to be paired up with a child, and then to receive that child. That can be very hard for parents, especially when a lot of that time is spent in kind of eager anticipation. You've done all you can do, and you've hurried up, and now you're waiting. It's also expensive. Again, it runs the gambit depending on what country you're adopting from or what organization you're using. But a lot of the numbers I found were close to anywhere from $20,000 to $40,000 to navigate the whole process of international adoption. It's also important to prepare parents that the period of transition for these kids and attachment to their families can be very variable depending on the child and depending on their life up until that point. It can be months, it can often take years. You can also do a little bit of research on different websites like the CDC, World Health Organization, things like that, to kind of look at country-specific risks and concerns, HIV rate, immunization quality, different infections you need to be worried about. You can also advise parents on the travel safety, when they are going to the country of origin to pick up the family. You can talk about things like malaria prophylaxis, diarrhea prevention, food safety, things like that. And this is also a great time to start modeling positive adoption language with these families. Adoptive families should be referred to as the real families. Siblings who are joining the family are real siblings. It's important to try not to refer to the biological mother as the natural mother, which implies that the adoptive mother is unnatural. Again, a child's race, identity, adoption, or birth country should never be the identifying characteristic for that child. And you want to try to avoid terms like orphaned, like abandoned, like given up, especially when you're talking to the child themselves, which can kind of imply a lower sense of worth. So it can be hard, but to avoid some of those words, but being especially mindful of that is an important thing to do and to model for the families. So we talk a little bit now about some of the prenatal exposures you can expect to see. One of the most common things that we see in internationally adopted children, primarily from countries of Eastern European origin, is fetal alcohol spectrum disorder. There is a characteristic facies that we can notice when we see these children. They may also have developmental delays, intellectual impairment, and things like that. We've seen this picture a lot of times throughout our studies. I included the picture on the right there. which shows these are all children that have been affected by fetal alcohol spectrum disorder, and that's why it's called a spectrum, because while at the top here, that is a very smooth philtrum, a very thin upper lip, very characteristic of fetal alcohol spectrum disorder. The kid on the bottom there, I would not call that a thin upper lip. I think the kid looks phenotypically normal to me. He's got, he or she has a defined philtrum, thick upper lip, things like that. So even though the characteristic facies might not be on there, it should be on your radar for something to be looking out for. Prenatal alcohol exposure is usually unknown, obviously, for a lot of these children. The diagnosis is clinical based on the facies, the growth delays, behavioral problems. There can be other factors that contribute to different long-term difficulties and neurobehavioral changes, but fetal alcohol spectrum should be on your list, your short differential. Adoption, it seems, has been proven to most likely ameliorate some of these long-term difficulties in the children. And one of our goals as pediatricians is to avoid the secondary disabilities that these kids can experience, things like the mental health problems, ADHD, conduct disorder, alcohol and drug abuse, depression, as well as other things like disrupted school experience, trouble with the law, inappropriate sexual behavior. All of these things have been associated with fetal alcohol spectrum disorder. Getting them plugged in with early intervention and their respective therapies is one of the most important things you can do as a pediatrician. A little bit about intrauterine drug exposure. We get a lot of training on this being in East Tennessee, but it's something that is worldwide as well. Again, much like alcohol, drug exposure, prenatal drug exposure is usually not known prior to adoption. They can have different long-term behavioral, cognitive, and social developmental problems. And much like alcohol exposure, adoption is most likely going to improve the long-term outcomes that you might expect to see in kids who've have experienced the intrauterine drug exposure. A little bit about perinatal stress. Dr. Wood actually gave a great presentation on the effects of stress earlier this year in a previous, I believe it was in their grand rounds. But these kids have lots of potential sources for stress simply by the fact that they have been raised in orphanages or institutions prior to adoption. Prenatal exposure, maternal depression, problems like abandonment, environmental deprivation, malnutrition, recurrent illnesses, as well as neglect and abuse. A lot of these have been proven to have long-term effects on growth, immune system problems, attachment, mental illness, as well as behavior. And while there probably is a genetic susceptibility for these kids, we unfortunately typically don't have that information as pediatricians treating internationally adopted kids. So the comprehensive health evaluation, there's nothing earth-shattering here. I just wanted to mention, a full physical exam is crucial in these kids. And there's a few other specific things that we should be mindful of when we're looking at kids, especially when they've come in for that first medical evaluation after they've been recently adopted. The first thing, obviously, is always to check their vital signs, but being especially mindful of the temperature. A fever in a child who has just been recently adopted from an overcrowded orphanage in Russia or China may not be a simple cold or things like that we can expect here. It could be something more. You want to look at the general appearance, again looking at facial signs of abuse, things like that. You want to see how alert and interactive they are. You also want to get all their measurements for height, weight, head circumference, things like that. Again, checking facial features for signs of dysmorphisms. You want to look at the philtrum, signs for fetal alcohol spectrum disorder. Some of the other things, you want to make sure you do a vision acuity screen. You should be checking their mouth for their teeth especially. A lot of times they can have poor dentition or signs of other infections or things like that with their teeth. You want to do a hearing screen. You want to check them obviously for murmurs, as well as other signs of things like rickets. Check their back for scoliosis and sacral dimples. Skin, you want to note scars, especially a scar on the left deltoid might signify that they've gotten the BCG vaccine. You also want to do developmental and mental health screening at this time. And this can be pretty difficult to do. One, obviously, the kids are oftentimes don't speak the same language, aren't familiar with the same benchmarks, things that we use to kind of evaluate development. They may not have ever had blocks to stack and things like that, things that can be, that we use typically for all of our screening. So they are most likely going to appear to be pretty significantly delayed, at least at that initial screen. And it's all the more important to continue to screen them and note hopefully their progression. After you do all this, this is also a great time to be thinking about the next couple steps that I'm going to be talking about, which is most likely labs and things like that. This would be a great time to place some EMLA cream on their arms, to get them trying to lower as much possible stress as you possibly can. We're going to need to get blood work from these kids, which we'll talk about in a little bit. But keep in mind that this whole thing is a very scary experience potentially for them. Not only has a stranger just stripped them from head to toe and looked them all over, but they're in a brand new culture, new family. They're going through a lot of stuff. So anything at all that we can do to minimize their experience is important at this time. I want to talk a little bit about malnutrition. This is an image of a young Chinese boy this is the image when he was first adopted, and then this is about 6 months later, and you can tell not only is he happier, he is also chunkier, which makes us happy. You want to talk about feeding practices explicitly with families. Kids who are voracious or ravenous eaters, which can also oftentimes be seen, should be allowed to eat freely, at least when they are first come over to the United States. That can be very important psychologically for these kids who may not have had access to enough or free food prior to the adoption. You can expect to see rapid weight gain and a quick return to normal. You may also see some laboratory or physical exam findings. All of these should be transient. If they are not, then there might be something else going on. If you aren't seeing this physical catch-up growth quickly within the first 6 months, you've got to start thinking about other things that could be potentially affecting their growth and development. Again, you want to, continue to do history and physical, calorie counts. You have to do a little bit more of labs to rule out other causes of poor growth. Things like H. pylori, stool test, bone age, sweat chloride test for CF, chest x-rays to rule out things like TB, renal ultrasound. If you were to see nephrolithiasis, you might start thinking about renal tubular acidosis as a cause for the poor growth. They can also experience some micronutrient deficiencies. They can be iron deficient. You can see this with anemia, cognitive delay. Zinc, zinc is very important for DNA, RNA, and protein synthesis. Low levels of zinc can cause growth delays as well as cognitive delays. Iodine deficiency, which is something we don't see very often in the United States, is something that could potentially be seen in children and international adoptees. It's important to do the neck exam on the physical exam, looking for things like goiters. Vitamin A deficiency can cause xerophthalmia. Vitamin E can cause weakness, ataxia, poor fine motor coordination. Vitamin C is fairly rare, but if you were to see, a hemorrhagic rash on the extremities, nausea, malaise, things like that, you could start to think maybe scurvy might be occurring. And then vitamin B12 deficiencies can cause a failure to thrive as well as developmental delays. Again, a little bit more about developmental delay. It's very common initially. Again, it's most likely probably due to the way that we are evaluating their development at this point. A lot of children develop very rapid catch-up, especially when it comes to motor delays. Things like language can lag behind the other areas. And while initially kids will recover, it's often very common to see school problems and learning disabilities later on in life. Small group of children are going to have very complex neurobehavioral disorders that you won't recover with simple encouragement and things like that, and that needs to be monitored for and managed if we needed. And again, there's lots of possible causes of developmental delay. You'll see lots of these lists are kind of redundant. It's the same things that can cause things over and over again: genetics, anatomy, prenatal exposures, malnutrition, stress, things like that. Moving in a little bit to the infectious disease portion of the talk here, we need to be concerned, or you need to be mindful that these kids are oftentimes coming from areas where diseases that we aren't we don't see on a regular basis might be prevalent. One of those diseases is tuberculosis. Adoptees coming from countries where a TB prevalence of greater than 20 per 100,000 need to be evaluated closely. You want to do a tuberculin skin test for kids ages 2 to 4. For older kids, age 5 to 14, you can either do a tuberculin skin test or a interferon gamma release assay like the quantiferon gold. Kids older than 15, you need to go ahead and get a chest x-ray to see if there's any pulmonary signs of tuberculosis, as well as sputum cultures and drug susceptibility testing. Kids who have been documented to have pulmonary disease are going to need to complete directly observed treatment prior to immigration. And children younger than 2, the Red Book recommends not necessarily testing unless they have come into contact with active TB, have an HIV infection, or have signs or symptoms of tuberculosis. You have to remember too that oftentimes these kids are coming from very crowded orphanages, so you need to have a pretty low threshold for going ahead and checking for tuberculosis. You would do that in this age group with a tuberculin skin test. Here's a map from the CDC that shows a little bit of the prevalence of tuberculosis. Again, the darker countries are areas where tuberculosis is more common. You have Central and South Africa, as well as Southeast Asia being the areas of most tuberculosis. This is from the 2018 Yellow Book as well. A little bit about the Bacillus Calmette-Guerin vaccine. I practiced saying that multiple times. The BCG. It is protecting against the lethal forms of TB. It's very common in different countries. It's protecting against things like meningitis with about 80% efficacy. It's lower for pulmonary disease. The important thing to know for us, and this is often a source of confusion, is that having received the BCG vaccine is not a contraindication to doing the tuberculin skin test. You can still do the TST even in kids who have evidence of having received the BCG vaccine. In children 5 years or older, the IGRA test can help determine if a positive tuberculin skin test is attributable to latent TB versus the BCG vaccine. And so children with a positive TST or IGRA that don't have any evidence of active disease most likely have a latent infection. This is when you would start calling your infectious disease people to most likely treat for latent TB. For malnourished children, you need to make sure that you test when they have been adequately nourished. And then you also want to repeat the tuberculin skin test in another 3 to 6 months to make sure, especially in the malnourished children, that you're getting accurate results. You can see, I mentioned it before, the scars on the left deltoid is common sometimes for kids to have multiple BCG vaccines. The more vaccines they get, the more likely they are to be positive on the tuberculin skin test. So it's important to look for all those. Again, positive TST, if you're worried about active disease, you want to get chest x-rays and start talking to your infectious disease docs about treatment. A little bit about hepatitis A. You want to screen for Hep A as well. For acute infections, you want to screen for hepatitis A IgM. For test for immunity, you want to test for the hepatitis A IgG and the IgM antibodies. Again, children who are incubating Hep A could affect adoptive families and others, so it's very important that not only the traveling members who are going to pick up the children, but also any close contacts in the home who are going to be interacting with the child be immunized themselves. But it's also important to be testing these kids for active infection just because you can give secondary prophylaxis to the people who come in close contact with them as well. For hepatitis B, all children should be screened for hepatitis B as well with the hepatitis B surface antigen, looking for chronic cases. Unimmunized children with a negative surface antigen and negative surface antibody should be immunized. Positive hepatitis surface antigen tests should be reported to the health department. And again, hepatitis B surface antigen positive children should be retested. You want to look for things like the core antibody as well as persistence of surface antigen, which for 6 months which can show a chronic Hep B infection. And then you would only ever test for hepatitis D in the setting of a chronic Hep B. This was an interesting article I found I want to talk about briefly. It was a 2008 study in Pediatrics that looked at 1,228 internationally adopted children from between 1999 and 2006, and it came out of the Cincinnati Children's International Adoption Center, which is where a lot of the best research is coming out of right now. They had the full hepatitis B panel performed, and they were included if these kids were evaluated with a full hepatitis B panel at the initial screening and then as well at the 6 months screening as well. Some of the results that they found, 31% of the kids that they initially tested were uninfected and unprotected. 65% were protected. 1.1% were infected and 2.9% had recovered. So the overall prevalence that they were able to discern was roughly about 4%. Of note, 59% of those that were unprotected and uninfected had documentations of having received the hepatitis B vaccine. So that's a little worrisome. What's also concerning, or why I thought this article was so interesting, is that at the 6 month test, they looked at the repeat testing for the initially negative results. They found that 33% of the uninfected were uninfected and unprotected, so they had not yet received their hepatitis B vaccine series. 64% were protected. 0.1% were acutely infected, and then 2% had recovered. So it said 0.7% acutely affected. This is a child who was initially negative when he first came over, and then positive 6 months later, showing signs of acute infection. Theories behind this is that he was infected very close to his adoption date, and so his initial screening was negative, but it just highlights the importance of testing these kids initially and then again at 6 months so you don't miss any other hepatitis B infections. And again, it's also important to remember all the traveling members and the members of the household to be vaccinated against hepatitis B as well. This is a slide from Up to Date that shows all of the ways you can interpret the hepatitis B panel. Despite having been tested on this countless times, I still have to look it up every single time. So don't feel bad if you do as well, but it's a way to look at whether or not kids have a chronic infection versus whether or not they have been vaccinated versus whether or not they have a past exposure. Routine screening for Hep C is also recommended. Hep C antibody with enzyme immunoassay should be the initial screen. Again, remember, if this is a young child, they can have maternal antibodies for up to 18 months. You want to confirm with a PCR as well. Some of the fun bugs and parasites that they can come in contact should prompt you to get some stool studies. Again, the initial study you might see might be a CBC that shows profound eosinophilia. That should make you think that there might be some parasitic infection going on. Three specimens of stool should be sent off for ovarian parasites. You especially want to be testing for Giardia and Cryptosporidium. Some of the more common bugs, Giardia intestinalis, Dientamoeba, Graphgillus, Hymenopilus species, Ascaris. Some of the less common ones are Strongyloides and Amoeba histolytica. Sub-Saharan Africa, you want to think about Cryptosporidium. And again, any of these internationally adopted children who have signs of profound diarrhea, especially bloody diarrhea, you should really start to expand your differential diagnosis and start thinking about some other potential infections that could be going on. HIV is also recommended to be screened for in all internationally adopted children, especially if they have active tuberculosis. You want to do a combined antigen antibody HIV test for both HIV 1 and 2, the initial screen. Again, remembering that some HIV antibodies in children may be due to maternal antibodies and maybe not a true infection. You want to test for HIV DNA with PCR to confirm. Syphilis is something that can sometimes go undiagnosed at birth, especially congenital syphilis. Children should be screened with both treponemal and non-treponemal serologic tests, regardless of their history or report of treatment. Again, this is the Hutchinson's teeth that you can see sometimes with syphilis. It's why you should do a good oral evaluation on your physical exam. Immunizations and vaccine of preventable diseases. This is a really big topic that still is a big source of confusion for a lot of pediatricians when they're evaluating kids who've been recently adopted. Previously, it was thought that the immunization records from internationally adopted children could essentially be ignored. They were considered unreliable, potentially forged, and you could just start like you're doing a catch-up immunization schedule with these kids. Some internationally adopted children we have evidence of them being unprotected with different measles infections happening in 2004, 288 different people from 18 different countries. However, more and more research is coming out that is saying that you can actually trust the immunization record. There was a study done in 2010, again out of Cincinnati, that looked at 748 kids and was testing the serologic testing to verify the immune status of these kids against vaccine preventable diseases, and it found a very high proportion of protective antibody levels in kids who had documentation of infections. They said that you could consider the birth country records to be valid and complete the immunization series as recommended by the AAP. Part of their motivation for that conclusion is they talked about how we as pediatricians should be administering, we should not be administering unnecessary vaccinations to these kids as another potential source of stress. We should be limiting the number of visits they have to come back to the clinic for, and we don't want to be sticking them every single time they come if it's unnecessary. Again, this article really argues that with the amount of protection they noted in these children, protective antibodies, they recommended neither doing re-immunization nor doing serologic testing. They said you can just trust it. This is obviously still makes a lot of pediatricians nervous. There's still a lot of uncertainty. While a lot of the recommendations are moving towards that direction, there hasn't been an official recommendation by the AAP. The Yellow Book kind of splits the uprights here and says you can basically do two things. You can re-immunize regardless of the immunization record, or you can test for antibody titers and re-immunize for those diseases that the child has not been, does not have protected titers against. The one little caveat is B. pertussis. Antibody titers do not correlate to immune status, but it says that you can look at diphtheria and tetanus and imply that B. pertussis has been immunized against. So this is a little bit of a catch-all in my opinion. You can kind of do either one you want to do, as long as you are being very mindful that these kids may need more vaccines. Some of the unusual infections, this is the stuff that gets us all excited and it's all over our tests and things like that, but things like typhoid fever, malaria, chagas, leprosy. You do need to have these on your differential for kids who are coming from other countries. However, it's very important to note that latent TB infection, intestinal parasites, and hepatitis B far exceeds any of these exotic infectious diseases. Again, as far as resources go, Up to Date still has a lot of good charts and things like that. This is a big summary of everything I just talked about, what tests we need to be getting and thinking about as far as the initial screening goes for our children. And this is the prevalence of the different infectious diseases. This is kind of what I was saying, how things like latent tuberculosis are across the board very common in these kids, as well as intestinal parasites, while other things are less common but still need to be screened for. There are other medical conditions that we need to be aware of as well. Anemia is commonly seen on the CBC in these newly arrived kiddos. Iron deficiency is a common cause, but there are also erythrocyte disorders that you need to be aware of. Iron repletion should be attempted before pursuing any other kind of sources of anemia. Children with the hyperchromic microcytic anemia and the low MCV should be further evaluated with hemoglobin electrophoresis after iron repletion. And because a lot of these kids are so young at the time of the adoption, and you may still have fetal hemoglobin and things like that, it can be difficult to suss out some of these disorders. Lead and environmental toxins are common. I included this picture because you can see kind of some of the evidence there of this child chewing on their crib, probably for kind of self-stimulatory reasons. It's possible that paint could include things like lead and things like that, other neurotoxicants. All children under the age of 6 who've come over from another country should be screened for lead exposure. Rickets is something as well that we should be mindful of. Interestingly enough, a lot of the children who have evidence of bony deformations and things like that on initial screen have something called healing rickets, and with malnutrition correction and micronutrient correction, a lot of times you guys will see the bowing of the legs and things like that resolve on their own. Uncertain age and precocious puberty is also something that's a bit of a hot topic now. For a long time it was thought that children of international adoption were at much higher risk for precocious puberty. Thoughts of, again, the early stress and things like that were thought to be the cause of that. It seems like most of the research now is really favoring this underrecorded age being the actual cause of the precocious puberty. And there's a couple reasons for that. The arguments for underrecorded age being the culprit. A lot of times kids who have precocious puberty here in the US will typically have a lower final height once puberty is done. That is not so for children with internationally adopted children who have signs of precocious puberty. So it's thought, for a couple other reasons. One of the reasons, we see kids who have really quick catch-up growth in their height right after being adopted, and that's been correlated with earlier onset of precocious puberty. Again, if you use underrecorded age as the reason for that, it makes sense that they would potentially have early signs, or quote-unquote early signs of puberty. It's something to be mindful of. It is still possible to have precocious puberty in internationally adopted children. However, the fact that they are adopted from another country does not put that at increased risk for precocious puberty. Attachment is a big thing, especially for parents, and a lot of times that will be some of the most distressing situations that new parents especially will talk to their pediatricians about. Again, orphanages and institutionalization, just by their very nature, kind of set kids up for problems with attachment. There's a wide spectrum of disordered attachment, from kids who are having things like reactive attachment disorder and really aren't showing any signs of attachment with anybody. And on the other side, there's the kids who are indiscriminately friendly and have learned to, be friendly with every single adult that they come in contact with. A big thing to talk to parents about is that it's been shown that a direct involvement with it from the caregiver is the critical foundation for building attachment. There is some suggestions that you should try to limit extra caregivers, daycare providers, different assistants and things like that, as a way to encourage attachment early on. Some of the factors interfering with attachment in institutionalized children. Again, this looks very similar to several of the lists we've already gone through: neglect, abuse, illnesses, things like that. Behavioral and mental disorders, again, there's likely a large genetic component to this. Unfortunately, we just don't have the information to know whether or not that's the case for a lot of these children. An unstable adoptive environment can most likely increase or exacerbate some of the expression of these mental disorders. And it has been shown that adoptees generally do have more behavioral and mental health disorders throughout childhood and adolescence. One article I found said that mental health disorders were more common in adopted adults, but most of these individuals, they said, were still having good mental and social adjustment as well. A little bit about language competence. I remember when we first adopted Claire, my Aunt Grace was dumbfounded at how in the world we would ever teach her English because she had spoken Chinese her whole life. It is true that they will likely have a delay in their language, but they are functionally communicative very quickly. And while the mastery of the language can be prolonged, these children are most likely going to not have any more language problems than any other children. They typically will not be bilingual unless they continue to be raised as bilingual. They typically lose their native language. Again, speech therapy and audiology referrals should be made early and get them involved as quickly as possible. School issues are another thing that pediatricians may continue to monitor these kids for. You may be asked to look into things like IEPs, as well as making sure that kids are in the correct grade for their stated age and things like that. And being mindful you want to make sure you reassure parents that classroom adjustment and things like that can take time as well. Culture and identity is another big thing that international adoptees are most likely going to continue to deal with throughout their life. It's important to be transparent and open with these families or with these children and to talk about things like differences in culture and identity. If there are ways for the international adoptee to have contact with anybody from their native country, that can be encouraged. Although having a truly open adoption is sometimes impossible in kids who there's no way to track down their biological family and things like that. And that can be really hard for some kids. Some of the unspoken problems that can be seen in international adoption. One of the things we've talked a lot about the stress on the child, but parental stress should not be dismissed. Again, the whole process itself can be very trying, very arduous, very stressful, let alone the actual physical traveling and picking up a child, but also having a new child and being a parent and all that stuff can be stressful. Disrupted adoptions are another very difficult thing to deal with. A lot of the themes that you might see in disrupted adoptions: lack of support post-placement, family strain, lack of parental empathy, incomplete attachment disorders for different reasons. Parents who've worked very hard to get these children adopted, sometimes it doesn't work out for a lot of different reasons, and these children are put up for adoption again. Sometimes, again, we talked about children having difficulty with attachment. It can be difficult for parents to attach as well to their adoptees. There's also the issue of very severely disturbed children seen from, most likely coming from orphanages with very dire, very low resource countries. And then also, there has been reports of child abuse. It seems unthinkable that a parent would go through such a difficult process to adopt a child, and then potentially abuse them. But there are reports of children unfortunately going through physical and sexual abuse after they've been adopted. So we have gone through a lot of stuff. That's essentially the end of my presentation. That was a lot of information to get through, and it can be kind of daunting when these kids are going to walk in through your door to remember everything you're supposed to do. I did want to highlight that there are specific international adoption clinics, and all of these states, kind of spread throughout the United States. All of their websites, as far as I could tell, are pretty universally great resources for what to do for as far as physical exam, all the different laboratory screens you need to do. I put these 4 in here just because they seem geographically to be the closest to us, but I think Charlottesville or Nashville, even Greenville might be the closest ones to us. There are emails all over there, and if you have any questions, specifically for providers and things like that, you can reach out to these different clinics. Other good resources would be the CDC, especially the Red Book for the different labs and vaccine recommendations. So hopefully I've convinced you that internationally adopted children require specialized medical attention. These children oftentimes have more than their fair share of lifetime experiences before they walk through the door. Even though they are very young, potentially when they walk through your door, is just being mindful of everything that they have been through, from abandonment to family structure disruptions, to illnesses, to infections, to prenatal exposures to drugs and alcohol, things like that. Simply being mindful of how much they've been through, I think is going to point us in the right direction. And while there's immediate medical concerns, the vaccines, the immediate infections that we need to be mindful of, it's important for us as pediatricians to continue to follow these kids lifelong and be mindful of all the effects that international adoption and growing up in orphanages and things like that can have on these children. So, thank you very much. That is my presentation. It's a little light reading for you if you're interested. No questions. Oh, shoot. Okay.
That was an excellent presentation.
Thank you.
I just had a question out of curiosity, and it's more of a legal question, so may not have a good answer for it. But just when these children are going through the process of adoption, and maybe you're seeing them in clinic for the first time, do you run any risk of jeopardizing the adoption process if you find something like HIV or tuberculosis or a reportable disease?
Right. Not that I'm aware of. I didn't see anything like that. You know, on the U.S. side, the family has already gone through a very strenuous kind of vetting process and legal paperwork and everything like that, home visits, things like that. And while families can, typically request children who are healthy versus children with special needs, where something like an HIV infection would be considered as special needs, everything they always sign always implies that if a special need were to arise, you would continue with the adoption process. So as far as I know, no, I don't think that you run any risk of jeopardizing anything. Yep, Victor.
So I know that you talked a little bit about how often there'll be like delays in speech or like motor activity, things like that. Whenever you first see them for that initial visit, are you already thinking, okay, let's go ahead and get you set up with an early intervention right at the first visit, or is it something you continue to evaluate over time with the referral?
I think so. I think most of the research I found is that earlier is better than playing catch up. And you're already essentially playing catch up with a lot of these children. Oftentimes the first appointment with a speech therapist or physical therapist is simply another evaluation by another specialist. So it may be that they see a perfectly developing kid and say, we actually don't need speech therapy. Here's a couple things to work on at home. But most of the resources I came across said early intervention is that early. You want to be jumping in there and making those referrals even after that initial visit. So, yeah, good question. Yeah, Dr. J.
So, and like Dr. Dodd said, thank you for the excellent presentation. I really enjoyed it. Couple of comments to actually Dr. Dodd's question and Victor's question. I had a family, really awesome family, one of the physicians is a parent, who actually came and saw me for a pre-adoption interview. It was the first time it had happened to me. They called and asked the clinic, and luckily it wasn't a call that was just blown away. They specifically said, can we come see her? We want to ask these questions. So I was actually able to direct them, because I think the families are given, the child has been tested for blah, 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 blah. So they actually got some of that paperwork and shared it with me, and we looked it over. to make sure they were comfortable with the adoption piece. And then I agree, early intervention is always something that helps these families. That child ended up needing speech therapy and kind of having to be helped, but I think that's always a good way to think about it. And then one last little fun fact, a couple of years ago, I think there was a movie that came out called Lion. I don't know if you all have seen it. And it's about an international adoptee who grows up and then actually spends some time trying to find his family. But very, very interesting and portrays a lot of the things that you talked about in your presentation. So if you haven't seen it, it would be a good one to see.
Yeah. Great, thank you. Okay. Yeah.
Nice talk. And by the way, there was somebody who was watching on the live stream who's one of my global health colleagues in another part of the university who is getting ready to adopt a child internationally in May. So she found it very helpful. So
great.
She texted me. Not that I looked at my phone during your talk.
Real-time feedback. This is great. Yeah.
One other just comment, and again, nice job. I think you sort of touched on this, but do realize that the vaccine schedule is sometimes different in other parts of the world. For instance, measles vaccine is very common to give that at 9 months of life. So you may have to do a little bit of catch up there because that doesn't count if you get your measles at 9 months in the U.S., but that's super common in other parts of the world. So just realize you may be dealing with different vaccine schedules. Kids who come from really remote areas in other parts of the world, sometimes the vaccine schedule is when the vaccine comes through the village and starts vaccinating everybody, whenever that may happen. So just be aware that, that there are differences there as you're trying to tease out the vaccine schedule.
Great
That's a really
point.
good point,
I think
yeah.
lots of parts of the world, there's what's called a 0 dose of polio. It's given at birth. And then the schedule starts instead of 8 weeks, it starts 6 weeks, like it's 1.5 months, 3 months, 4.5 months. So
Yeah.
the schedule can be and is very different.
That's a good point. Okay, thank you very much.
And last little
Oh,
piece,
yep,
we
Emily.
really apologize, there was no food. I have some food cards, coupons that the cafeteria brought up for us. Apparently, the room change was not conveyed to them correctly. They set it up downstairs where we usually have our grand rounds, and people already started eating it. So they
Sounds right.
I apologize, but come get some.
Nice to know.